Good afternoon, everyone. We want to thank everyone for securing some time to log in for this session, our viewers and everyone who has logged in for our 36th session about bands and specific thermal and electrical bands. We're having experts who have been handling different cases. We're having also an Afande who has also responded to fire, who will be also sharing with us how they have always dealt with it. So we want to thank you, everyone. Just expect the best. We shall start with introducing ourselves. My name is Alenyo Jonan. I'm an EMT with KCCA and also a paramedic student at Rubaga Hospital Training Institute. I'll be the moderator of today's session. I'll give an opportunity to our experts to also introduce themselves. And then we proceed.
My name is Nacho, and I'm a nurse at the Bands Unit, Kiruddu National Referral Hospital.
Okay, thank you.
Good afternoon. I am Dr. Harriet Chen. I am a emergency physician and a C educator at Makerere University, Malago Hospital.
Good afternoon, everybody. I'm Sergeant Walusimbi, Elly. I work with the Directorate of Fire Prevention and Rescue Services. I'm a trainer there, at the same time a safety officer. I work mostly with community when it comes to bands. At least I'm in that very field.
Thank you very much. Dr. Alenyo. Dr. Alenyo, you can introduce yourself. As you wait for Dr. Alenyo, Dr. Jessica, you can introduce yourself.
Hi, everyone. My name is Jessica Pelletier. I'm an emergency medicine physician at Washington University in St. Louis, and I'm very excited to be here. Thanks for having me.
Thank you very much. Lastly, we shall have Dr. Agaba Brand, the clinical advisor at SID Global, to introduce himself.
Thank you very much, Moderator. My name is Agaba Brian, and I'm the clinical advisor at SID Global Health. Thank you all for logging on to this session, and have a good afternoon. So I just have two pieces of information to pass across. We completed phase 2 of the emergency medicine echo trainings some time back, and I'm happy to report that the issuance of certificates for all eligible participants in phase 2 is complete. This current phase, that is phase 3, which is trauma, has 7 sessions, 1 more to go, and we shall issue certificates for persons that have attended 5 out of 7 sessions, and we shall start issuing them up in May. This is also coming up. So after that, we shall move to the next phase, which is phase 4, and this will be approach to key syndromes. We'll have 16 sessions. Please keep logging on as you've been doing, as there's a lot to learn in that phase. The second piece of information is about the REACT teams that are being formed in the hospitals. You've seen Ministry of Health and SID Global Health personnel in your hospitals trying to set up these REACT teams that are envisioned to improve care for emergency conditions in your hospitals. So all hospitals that are participating have been visited except the ones in Kampala, and trainings of these selected participants is to begin in May. We shall begin with basic emergency care trainings, and please keep an eye out for these trainings in your hospitals and attend them. Thank you very much, and I wish you a wonderful session today. Over to you, Moderator.
Okay, thank you very much. We want to thank SID Global, the ECHO project, and also Ministry of Health under the Department of EMS and the Emergency Care Society of Uganda for always organizing such sessions. Trust me, most of the healthy petitioners will testify that ever since this session started, there is some change in handling most of the cases. We have been handling different cases, how to handle different emergencies, and today we are handling bands. Trust me, by the end of this session, hearing the sharing from the experts how they have been handling or how they would handle it in case they receive such a case. It will be beneficial to us, the people who are still under, to learn more. In case we receive such cases, we're able to manage. We are going to be doing our pretest. We're going to be doing our pretest on the, as we follow. We shall be doing our pretest and also receiving the expectations from the people who are on the chat and also following online. Okay, before we do our pretest, Mr. Eliab Turyagumanawe, please introduce yourself. You can unmute. Mr. Eliab. Okay, sorry for that. As we are preparing for our pretest, it will be presented, and we expect you to go through the pretest. And also we're expecting to receive the expectations from you as our case presenter is preparing. Thank you very much. Okay, still we want to thank people who are following in. We see there's someone following in from Nigeria. Thank you very much for logging in. You can't hear anything. Yeah, let us try to work on it. We are working on that. On it. Okay, so our pretest is running, and as the pretest is running, we are welcoming in the expectations from the people who have logged in. Maybe try to check with your network, the people who are not very well, check for the best network. Yeah. Okay, we are waiting for the expectations as we are doing our pretest. Yeah, our network is well. Try just to look for a better network. Try to position yourself. Yeah, our network is well. Yeah, the people asking the pretest has been sent. Okay, so as we're doing our pretest, we shall be having sharing from different experts, and we expect to learn a lot from today's sessions. Burns being one of the emergencies that has claimed a lot of lives of people. Usually we have been overseeing it, we neglect it, but it is an emergency, or these are cases that have always killed people. And it goes back to how do we handle it in the pre-hospital and also in the hospital after receiving that patient. So we have different experts. We shall be having the sharing from the Afande, from the police, how they handle fire, and also will also help us to give us on the preventions. How can we prevent the fire from starting or to prevent the burns? We shall have a nurse who is working with the Kiruddu burn unit. She has enough experience. She has faced patients with burns, and out of this experience, we expect the rest of the nurses and also the EMTs, the paramedics, to learn from our nurse the experience that she'll be sharing with us. We also have Dr. Alenyo and Dr. Jessica, a physician from Washington. They will be also sharing with us the experience, so let us be expectant to learn a lot. Thank you very much. Okay, Corinne, yeah, they will help you in getting your CPD points. I think you need to work on your network, Hussein, the pretest. Our network is well. As we still do our pretest, allow me to recognize the presence of Dr. Alenyo, and I will give her an opportunity to introduce herself.
Thank you very much. As you said, I'm Dr. Rose Alenyo. I'm a lecturer at Makerere University, and I'm also a consultant plastic surgeon at Kiruddu National Referral Hospital.
Okay, thank you very much.
I'm happy to be here.
Yeah, we are glad to have you, our expert, and we expect to learn a lot from you. Yeah, we being the nurses and the pre-hospital care givers, we expect to learn a lot on what you expect us to have done for this patient, because our aim is to save someone's life. So if we go wrong, maybe someone's life might not be saved. Thank you very much. Okay. At this juncture, Mr. Eliab Turyagumanawe, if you're ready, we shall have a case presentation.
Hello.
Yes, Mr. Eliab, we can hear you.
Good afternoon. Yeah, good afternoon, everyone. Thank you, moderator, for giving me this opportunity to share my presentation. My name is Eliab Turyagumanawe. I'm an acting reg, Hoima region. I'm a critical care nurse specialist, and I'm a Eliab team member. So I'm going to share a case presentation on the burn injury. So let me go straight to the case. MM, a 1 year and 8-month-old baby, brought in by his mother, complaining that he was burnt by fire 6 days ago. Mother said the child was first rushed to the clinic, where he was managed for 3 days without improvement observed. She then decided to take the child home and started smearing herbal medicines on the wounds until when the condition worsened, that the wound started discharging pus. Then the mother decided to bring the child to the hospital. In the hospital, we did a quick ABCD approach on the child, where we looked at airway. And on airway assessment, the child was not in distress. The child was able to cry and call his mother. So we thought the air was open and clear. We didn't do any intervention on that. Then we checked breathing. We counted the respiratory rates, which were 25 breaths per minute. The SpO2 was 97 at room air, and the chest was clear with equal air in from auscultation. So our plan was to monitor the SpO2. Since the child had also burns on the face, we suspected maybe the child could either deteriorate, maybe in case of the burn, could have inhaled a burn deep, which we didn't ascertain. And on saturation, the extremities were severely burnt and dressed, so we couldn't ascertain, we couldn't observe or examine the extremities. But there was no central cyanosis on the skin observed. There was no pallor. And we decided to give fluids, 100 mils 8 hourly. That was the plan on our immediate plan. And on disability, we looked at this, we scored the child by AVPU, where the child was alert. We also tried to check the body weight later, which was 11.5. We exposed this child, and on exposure, we saw that the child was burnt on the face. The mother had covered the baby. So when we exposed, we saw burns on the face, the forearms, the lower limbs, also which included the digits, both the lower digits. And our plan here was to do debridements, since the fore left hand was gangrenous. So we decided to add or minus amputation under consent, if only the fingers were not viable. We quickly did a sample history where we looked at the signs and symptoms of this child. There was past discharge from the wounds. The child had fever. There was pain, because this was evidenced by the child crying every time. That wasn't on touching the child. Then we didn't note any allergies. There was no history of non-medications from the clinic, since this child didn't come with a referral form. However, we noted the history of herbal medications being given the child by the mother when the mother ran away from the first clinic. On the past medical history, we didn't appreciate any non-chronic illnesses since birth. And we observed that the child was fully immunized when we checked the immunization card. About the history of meal, the mother reported the child had a meal 6 hours, 6 hours since morning, 6 hours prior to morning time. And the events which occurred, according to the mother, this child was caught by fire while he was in the garden. And then we listed our problems as one, extensive septic burns and gangrenous left hand. And then you can appreciate one of the pictorials which I managed to post. That was after 3.5 weeks of management. I didn't have a picture on admission. This was so unfortunate, but I managed to take the picture. 3 weeks of management, 3.5 weeks of management. So our plan for follow-up or intervention, we did CBC, and the HB was 7.3. It wasn't worrying. I think this is because the sepsis had set in, and there was hypochromic anemia being reviewed on the CBC. I think this was attributed to the sepsis. The MRDT was done and was positive. We gave Flucamox, we gave Artesunate, we gave Metro, oral morphine for pain, fluid, we gave normal saline, dextrose 10%, and our plan was also to do direct dressing, and then give a high protein diet, rectal paracetamol. However, this child was kept on being reviewed and the child had improved. So we decided to discharge the mother on request since the child had improved and we thought the sepsis was going down. You can see when you observe on the picture, the wounds, the burn wounds were already healing, though they were forming some contractures when you look at the picture very well. But where you see the bandage, there was still some cut discharge, so we decided to discharge to the nearest facility on request so that they keep changing the dressing. Yeah, that was brief about the case presentation. I beg to submit.
Okay, thank you very much, Mr. Eliab, for such a presentation. And we thank you for going forward to do more research and give us such a presentation because it is realistic. And now, since we have the, we shall discuss referring from the real scenario that happened. So at this juncture in moment, having presented the scenario, the presentation, in emergency medical services, when there is an emergency, it starts from the pre-hospital care. So at this time in moment, I will give an opportunity to Afande Walusimbi to give us how, out of experience, how they have been responding to such cases in case there is a victim. How do they manage it before they take that person to the hospital? And also we expect to get some preservation, how we can prevent the fire, everything. Thank you very much.
All right, thank you very much. I'm glad to be here with my doctor, Dr. Alenyo. I'm Walusimbi, as I told you, but I was once also a victim of burns. I ever got burnt in 2010, seriously. But my surviving and being here now, it was through the grace of God and the work of Dr. Alenyo. All what I have in his hands, all why I have also some photos, maybe I'll share with you later. I got burned. You know, when it comes to burns, I'm a victim myself. So in most cases, the department where I work, there are so many cases we normally interact with people who have got burned. And we have realized there is a certain age, they get different types of, they get burned differently. We have people who are between 10 to 30 years. They normally get burned, more so women. In that age category, they normally get burned and then they exposure to flames because they normally cook. In the process of cooking, they can get those injuries and then they end up getting burned. Then you have those who are under like 10 years. They normally also get burned because some are crawling, they go to kitchen, they touch different things, they also get burned. We have also come across such people. We have also the adult males. They normally get burned due to exposure to flames and faulty electric wires. Sometimes our own colleagues, when we normally go to different scenes, they can get burned there. Then also, the babies, all these infants are most risky. This one, they normally get burned because of these nets, bed nets. They normally take them to bed and then sometimes they put these candles near the bed when there is no power. It ends up, in most cases, in so many these severe injuries, and others also, they get some fatal accidents normally when it comes to that. But it comes as a result when somebody has put maybe a candle on the head of the bed on those wooden pieces, and then it grabs the net, the fire grabs the net and the baby is inside. Most cases we have got such cases, and then so many people have got burnt there. Then also, we have got also people have got burnt, or these burns due to chemicals. Most people normally get these misunderstandings, and they normally resort to go and then get this acid and other chemicals they pour. That age bracket is between 20 to 30. We normally get such people and they normally respond to such people who have got those bans. Then also we have this one who have got like these other people maybe can get banned because of some negligence. Maybe he was handling a certain chemical but did not know its impact on the body. He was handling it carelessly. Others at workplace, more so these welders, they normally take it light, they end up get banned. We normally come across such people. And in most cases, they normally call us, is fire here, and you end up getting. Then others, we normally also, as fire brigade, most let me give you be specific, like last year, we lost students and others got banned, like 18 of them got banned and died. Others sustained serious injuries. Over 62 schools got banned severely and very many injured in those schools. We have come to realize that there are so many causes, what caused that, and there are so many victims were there due to those bans. So different scenarios, they always come up with people who have got banned. And as police, we have come up with a resolution to move around to go and sensitize such people. But we have realized there's a certain period where you see there are so many fires and so many victims of, during holiday times, you find so many children banned. During the school times, you find so many students have got banned. During the holidays, like in around November to January, you find adults like more so ladies between 20 to 30, they normally get banned due to these people who are maybe taking revenge to them. They pour these chemicals on them, others they set fire where they stay and they get injured. So they have asked, how do we handle such? In most cases, when they call us, in most cases we normally, we used to go the way we used to go, and then we just do it locally. You get somebody banned, maybe you pour water, this clean water on the wound so that you reduce the movement of heat to reduce the movement of heat in that very affected part to other parts of the body. Others, we used to move with ambulances where cases are very complicated. We just put them in ambulance and take them to the hospital. Sometimes the victim can tell you, take me to this hospital, or if doesn't know, we normally take them to Mulago, this time specifically Kiruddu. We have cases where we go to different scenes and find people inside. And the facility is burning and people inside are also burning. I've ever fallen a victim. I've got banned 14 times when I'm trying to rescue such people. You find the house is burning and there are children inside or other people. Or sometimes you reach a scene, you find the children are inside. In the process, the mother also comes from where he had gone and inside also to enter and join the other group. And the process, you have to go inside and rescue. In the process of rescuing, you have sustained injuries and also the victims have sustained injuries. What do? We just come out, bring them out, we give the first aid. In most cases, we normally give that one of pouring them water, cover them with blankets, and then take them to the hospital. That's basically what we do according to that's the level where we normally end. Other things, normally take them to the hospital. But before we reach burns, what causes these fires? Some of them are arson fires. Arson just deliberate setting of fire on any valuable property. People get misunderstanding and then they set fire on a property, more so houses. And you find in most cases those houses, there are people inside. They have got misunderstanding because of land, and somebody resorts to set the fire on the house or on the property. In most cases, it ends up people getting those burns. Others, that is revenge. Others are sustained burns because they are trying to rescue. Others they set fire because maybe has been terminated or has been warned that is going to be terminated from work. He ends up setting fire at the workplace, and then in the process, and that scaffolds everybody now to rescue himself or herself. Some people normally sustain burns when they are trying to. We have got that so many scenarios of such people. Then also we have the poor wiring in different houses. You find somebody did wiring, maybe wired the house some 10 years ago, he has never checked. And in most cases, there is that electricity and wiring normally causes those burns. In the process, people trying to touch things which they don't know, and they end up being electrocuted. And in the process, they sustain those serious burns. We have also these people who normally, they find that maybe like workplace, he has maybe told him that auditors are coming and realizes that it's going to be, the figures might not be balancing well. He decided to set the workplace on fire. More so office fires we normally hear. Office fires normally are set by the workers themselves. And in the process of rescuing property, this one is removing this one is removing this, most people normally sustain serious burns. And others, they set fire when they don't know how to set fire. Like a case in point, we have somebody, he decided to say, we are doing a drill. We told him, let us do it because we know it. He said, no, this one I'm an expert. He got a jerrycan of petrol and then set fire in a container. He realized that he had set a little fire. He decided to get a jerrycan of petrol and he added on a flame. He exploded. And seriously, that person sustained serious injuries. Of recently, I normally work with the oil company. I normally go there to advise on safety issues. To advise somebody, don't weld a truck which has offloaded the fuel. He refused. He said, I've worked in this department for over 10 years. He refused. He entered in a truck, in a truck which has just loaded in one of the compartments and wanted to do some modifications that he had washed. He exploded with that tanker and then got serious burns recently. Others, they normally, because those welders, we normally also come across such people, because some of them they take it lightly and they just connect things in just arrogant way. They end up sustaining serious burns. So you have got such people, they end up getting burned and the entire facility also get burned. Others, they deal with the cylinders, like these LPG cylinders, the gas cylinders actually. They don't know how to use it. Somebody will get a cylinder from these outlets and takes it at home. And if there is any leakage, in most cases you have got it that there is a leakage and somebody did not know, it ends up burning the entire house, and most of the dwellers in that very house, they get burned because of gas. There is that problem that on the market, people are no longer using much charcoal. They have taken another route of this gas, and then they have ended up getting burned because there is no clear precaution how to use gas. Recently, one of the gas plant, it caught fire, the offloading gas. It caught fire in Chengera here, in one of the town councils around Wachiso, along Masaka Road. It was offloading gas, this LPG gas, and then the remaining residues, he decided to pour it outside. Yet somebody, something like 20 meters, had already lit a charcoal stove. The whole of that place got burnt and almost 4 people died. 4 people died and 7 sustained serious injuries. They were treated in Mulago. We responded there, and recently also it had caught again, but we had told them what to do in case of gas. So there are so many ways how fire starts and people get burnt, but basically arson, electricity, and very few cases we have got where there is these chemicals, but they are there, like towards the end of last year, a vehicle overturned around the Constitutional Square and was carrying sulfuric acid. People for them came to fetch, thinking that maybe it is a golden opportunity, they are going to get rich very fast. The first people to touch, they got serious burns and they took off. So it fell opposite that Crane Bank, in front of Crane Bank, and then so many people. And also some of the firemen, sometimes they are called at different scenes and they end up getting burnt because sometimes you enter a facility and you don't know what is inside. So that's how those burns go. There are so many, maybe a little later burns. Thank you.
Thank you very much, Afande Walusimbi. He has really tried to bring out the real experience that he has faced, giving realistic examples. And as we all see him, that he has been a victim trying to respond. And this is a lesson to us, the pre-hospital and also the healthy workers who might want to save someone who is being burnt, to consider the safety of the person who is responding first. So you should always put your safety first before you respond. If you can't, then call for help. Let us always rely on calling for help. Thank you very much, Mr. Walusimbi. You pointed out some points on the causes of fire, which is usually no clear precautions on how to use gas. Encourage people who are using gas. Maybe you should always get more advice on how to use gas to prevent yourself from getting the burns. Thank you very much. So in the chain of survival from the pre-hospital, we expect if the pre-hospital, the fire brigade, and then the paramedics and the EMTs, after responding, they have to take this patient to the hospital. He has given us how they manage pouring water to cool the burnt area or the burnt patient. Then they cover to prevent the patient from going into shock. Now we want to see how do the people in the hospital at the emergency unit are ready to work on this patient. Since all the people in this field of EMS, our aim is to save that person's life. I will give an opportunity to Dr. Rose Alenyo, and he will take us through how they usually handle such cases after receiving them. Mr. Jessica, okay, sorry. Sorry for that. We shall give the opportunity to Dr. Jessica to tell us how they usually handle such cases after receiving them as an emergency unit. Thank you very much.
Thank you so much. And I'll have Dr. Alenyo interject at any time during my presentation if she has additional points to add regarding local context. As I said, I work at Washington University in St. Louis in the US, and I'm going to share my presentation now. Please let me know if you can see these slides. Are you able to see?
Yes, we're able to see.
Excellent, thank you. So we're going to talk about burns, not only thermal burns, but also chemical and electrical injuries. I want to thank my colleague, Dr. Emily Klossner, who is a resident physician at Washington University in St. Louis and previously worked for the CDC, doing quite a bit of global health work. She helped with presentation preparation. We don't have any financial disclosures. As I mentioned, we will speak about thermal, chemical, and electrical injuries, and then we'll do a quick summary, and I'll have Dr. Alenyo discuss the local context. Let's start with thermal injuries. So first, injuries caused by heat, whether that be fire, steam, or hot objects, and we classify burns by how deep they go and what percentage of the body surface area is burned. Burns that affect more than 20% of body surface are very concerning and cause systemic swelling, so full body swelling, not only localized injury. We can think of burns according to this new model, called burns first, second, and third degree, but now we refer to them as superficial thickness, which is what used to be called a first-degree burn, superficial and deep partial thickness, which is what used to be called a second-degree burn, and third degree is a full thickness burn. Realize that deep partial thickness and full thickness burns both need skin grafting. So these are very severe injuries. The rule of nines to calculate how much of the body surface area is burned. Please note here that 18% for a child refers to the entire head and 9% for the adult refers to the entire head, meaning it's 4.5% in the front and 4.5% in the back. We only calculate partial thickness and full thickness burns as part of this rule of nines. So first-degree burns or superficial burns do not count. If a burn is oddly shaped, you can use the palm of a patient's hand to estimate 1% of the body surface area burned. Let's discuss the ABCDEs of thermal injury, and we'll start with airway, the most important. So direct inhalation of smoke, fire, chemicals can all cause injury to the airway. Remember that localized edema from burns can also cause airway compromise, and the entire body can become swollen if you have a significant percent of the body that's burned. Some reasons to suspect airway compromise in thermal burn patient would be cough or stridor. This is a late finding, and this is an emergency that needs to be managed quickly. Changes in their voice, carbonaceous sputum, meaning soot in their nares or in their mouth, and if there are burns on the face, head, or neck, or singed hairs on the face. The pathophysiology behind airway compromise in these situations is that sloughing of the epithelial lining can actually clog the airway, and this can be delayed by up to 4 to 5 days after a burn injury. Patients tend to hypersecrete mucus during burn injuries, and that can also obstruct airways. The cilia, which normally help foreign bodies and soot out of the way, can become damaged, and this leads to clogging of the airways as well. You can have an inflammatory effect from burns, and pulmonary surfactant, which we know helps to keep the airways open, prevent atelectasis, and facilitate airway recruitment, can actually become inactivated by burns. So there are a lot of reasons that burn patients can have difficulty with their airway. I think this image of a patient's glottis at the beginning of a burn injury, so right after injury, and then an hour later helps demonstrate the severity of the edema that can develop with thermal injury, and realize that burn injuries can cause airway swelling that is not immediately obvious at first and will develop over hours. And so that's why immediate consideration for airway management is important. For B, breathing, we rarely see direct burn injuries to the lower airway, but something we do need to think about is whether patients inhaled substances in the smoke that could be compromising the airway, and whether they have full chest burns, especially circumferential burns that go all the way around the body. If that's compromising breathing, then this needs to be managed with what's called an escharotomy, where we make incisions along these lines indicated in orange through the soft tissue to help relieve the restriction so that the patient can breathe. Also be careful not to over fluid resuscitate the patient, because this can lead to pulmonary edema, and fluid on the lung will lose their ability to breathe appropriately. For circulation, my colleague already mentioned the importance of fluid management in the setting of burns, but realize that when a patient has over 20 body surface area burns, the protective covering of the body that insulates them and prevents them from insensible fluid losses, and so they quickly lose that known as burn shock. Like we said, giving too much fluid can cause pulmonary edema. So the key here is to guide your fluid resuscitation based on the patient's urine output. So we have a few formulas that we do use, and I'll discuss those on the next slide, but the key is to make sure that adults are making 0.5 to 1 milliliters per kilogram per hour of urine, and for children, 1 to 1.5 milliliters per kilogram per hour. And this may mean that you need to have a Foley catheter inserted to appropriately track the urine volume. The formulas we may be familiar with are the Parkland formula and the Brook formula. The Brook formula actually has better evidence at this point because there's less likelihood of over fluid resuscitate the patient, causing edema, pulmonary edema. So I would recommend you consider using the Brook formula. So this is total body surface area burned times the patient's weight in kilograms times 2, and that's the volume that you give over 24 hours. Half of the volume should be given in the first 8 hours and the remaining volume over the next 16 hours. There's not as good evidence for using colloids like albumin, so I would recommend using crystalloids. In terms of D, disability, burn patients may have decreased level of consciousness if they had additional injuries, such as head injury during their trauma. So please make sure to screen for that. If they're not breathing or oxygenating, ventilating appropriately, or if they've inhaled chemicals like carbon monoxide or cyanide. So keep this in mind. I've placed an image of the Glasgow Coma scale in the bottom right as a reminder that we should be calculating this on our patients. For exposure, I already mentioned carbon monoxide and cyanide. Other potential exposures to think about would be tetanus. So is the patient's tetanus vaccination status up to date? We need to consider local wound care. So with most burns, we should avoid blister popping. So I would not unroof or pop the blisters. Applying an antibiotic ointment and following your local wound care protocols is ideal. You do not want to apply cold water to the burn since this can lead to hypothermia. Remember that patients with greater than 20% body surface area burned have problems with thermoregulation or temperature regulation. So avoid putting cold water on them. And my colleagues will speak more about local wound care after this presentation. You should remove all clothing from burn patients, and if their clothing is stuck to their burns, simply cut around the area burned. So when to transfer for a higher level of care? If the patient has other traumatic injuries that would require management at a more advanced center, if a great amount of the body surface area is burned, so greater than 20%, if they have circumferential burns that required escharotomy, those are all major reasons to send a patient to higher level of care. So take home points for thermal injuries. We calculate the body surface area burned and use that to guide our fluid management. Remember that only partial and full thickness burns count for that total body surface area burned. And we resuscitate using Park or Brook formula, ideally Brook, and guide our fluids based on urine output. Let's move on to chemical injuries. So reminder that this is the pH scale, with 7 being neutral. On the far right would be an alkaline substance or alkali, and on the far left, an acidic substance. The further you move from 7 in either direction, the more likely a substance is to cause a chemical burn or injury. Alkali burns to coaction necrosis, which means that they turn the tissues to liquid, and these burns tend to go much deeper than acid burns. Acid burns, on the other hand, cause coagulation necrosis, which means that they make the tissues firm, hard, and not functioning properly. They do have a limited depth of injury and are typically less severe. For airway and breathing management, we approach chemical burns the same way we would with thermal injuries. Remember that inhaling chemicals can lead to airway edema, and we should consider early intubation in these cases. If we too much flu patients, they may also develop pulmonary edema. And remember what we discussed earlier about circumferential burns, or burns all the way around the chest that restrict breathing, and the importance of considering escharotomy. For C, circulation, large surface area chemical burns should be managed similarly to thermal burns by providing IV fluid resuscitation. And when calculating body surface burn, remember to use partial or full thickness injury. Some chemicals like hydrofluoric acid can cause low calcium and low magnesium, so we should have a low threshold to give these supplements when needed. For D, disability, the same principles apply as we mentioned earlier. So ruling out other injuries such as head injury that would compromise the patient's neurologic status, and calculating a Glasgow Coma status by whatever chemical it was to, so consider this. For exposure here is to provide a personal protective equipment to your injury. The main principles here are revolving around decontamination. So you need to remove the patient's clothing and ensure that you brush off any visible chemicals before you rinse them with crystalloids or water. The key here for cleaning the patient is to make sure that you test the pH of the fluid coming off of the body as you rinse them. And once you have reached a neutral pH, like 7, you know that you have appropriately decontaminated the patient. If the acid or base is still present, then you haven't finished cleaning them off. Acid burns will need a little bit less irrigation than alkali burns typically. If possible, make sure to irrigate in a way that does not drip the contaminated fluid onto non-burned areas of the body, because you do not want to cause further exposure and injury. We should avoid using high pressure fluid irrigation because this can drive the chemical into the skin. And make sure to cover the patient after the irrigation is complete so that they do not develop hypothermia. Same principle applies to what we do thermal burns that differing with dry lime or concrete exposure. Make sure you brush off everything that you can see before you irrigate the patient, since wetting the dry lime will actually activate it and cause further burns. The same thing goes for metals. You do not want to rinse these while they're present on the skin. We recommend that you brush off all visible metal and then put oil on the skin and rub it until cleaned. Remaining particles can be removed in the operating room if necessary. For phenols, which are a certain type of chemical, use polyethylene glycol sponges to help decontaminate them before you wash with water, and these are unique exceptions. Precautions to take. Don't ever try to neutralize the burn with another substance. For example, if the patient had an alkali burn, do not put an acid on them to try and neutralize it, since this will actually make the burns worse. For a patient who's ingested a chemical, like swallowing an acid or an alkali, do not try to induce vomiting because this will re-expose the esophagus and the GI chemical and cause further burn injuries. This also puts them at risk for aspirating the chemical, leading to lung injury and damage. One aspect of the secondary survey that I wanted to cover for chemical injuries is specifically related to the eyes. In this image, you can see something called a Morgan lens, which is the contact lens for the eye. If you have this at your facility, you can certainly use it, but it's not absolutely necessary. You need to hold the patient's eye open and irrigate it with water or crystalloid solution like normal saline or lactated ringers continuously until the pH coming out of the eye is somewhere around 7 to 7.2. Some sources will say 7 to 7.4, which is considered neutral. There's not a specific duration of time to rinse or volume to rinse with. This depends on the substance, and you need to get to that neutral pH. So take home points. Make sure that your staff do not become secondary victims, and so they need to have appropriate personal protective equipment. Always remove the patient's clothing and fully decontaminate them, and irrigation is the most important part of treatment. I'm going to move on to lightning and electrical injuries now. Before we discuss these, we need a little bit of background on the pathophysiology. Alternating current is more dangerous than direct current, and the reason for this is that alternating current, also known as AC, can cause tetany, so the muscle spasm, and the patient will not be able to let go of the source of the electricity, and that means that they're further exposed to the burn. AC sources can be found in the home or in industrial areas, and DC sources are typically found in the home. Lightning injuries are unique because lightning tends to arc over the surface of the body, meaning that you don't see entry and exit wounds like you would with typical home electrical or industrial electrical injury. Regardless of whether we are dealing with lightning or electrical injuries, you remember that the burns that are occurring internally or the injuries that occur internally may be bigger than expect based on the external physical exam. So maintain a high index of suspicion for deep injury. Remember that electricity has to flow between 2 points, and that's typically the lightning and the ground, or the source of power and the ground, or some other object. And so you should look for where the lightning or the electricity entered and exited the body to help you figure out what things might be damaged or injured. Let's talk about airway and breathing management. Most of us are familiar with typical triage algorithms in mass casualty incidents like START triage, where patients who are not breathing or do not have a pulse are considered deceased or expectant. So we usually tag them black. This is different in lightning and electrical injuries. We use a concept called reverse triage, which means that patients who are not breathing are actually assessed and managed first. And the reason for this is that lightning and electricity can cause respiratory paralysis, which is temporary. So patients will eventually start breathing again, but we need to support them until that time. So the components of reverse triage initially are scene safety, which is no different from our usual triage algorithms. And people who are walking around are considered green or minor. The difference here from usual algorithms is that if someone is not walking and not breathing or pulseless, we need to manage them first. So they are tagged red instead of black. So we should reposition the airway, ventilate them as needed, and if they are pulseless, we manage them with our typical resuscitation algorithm, like advanced cardiac life support. So we would go ahead and do CPR, and if they're in a shockable rhythm, like ventricular tachycardia or ventricular fibrillation, we should provide defibrillations as prescribed by these algorithms. And patients who've been exposed to AC power are actually at higher risk for ventricular fibrillation. So they are more likely to require defibrillation. Let's talk about the ECG, the electrocardiogram. Lightning and electrical injuries in general put patients at risk for many dysrhythmias, including ventricular fibrillation, like we've mentioned, but also atrial fibrillation and other ECG abnormalities like QT prolongation and T-wave inversions. So make sure that you obtain an ECG on every patient with a lightning or electrical injury, especially if they've been exposed to high power injury. Let's talk about fluid resuscitation. So this is similar to our fluid resuscitation for thermal and chemical injuries. We should guide our fluid administration of crystalloids by the urine output. And the goals here are a little bit higher than for patients with thermal or chemical injuries. 1 to 1.5 milliliters per kilogram per hour for adults and 1.5 to 2 for children. And the reason that these fluid resuscitation urine output goals are higher is, like I mentioned, electrical injuries can cause deeper burns than you might expect based on surface injury. So deep injury means that they will have more requirements for fluids. In terms of the disability survey, realize that electrical injuries can cause autonomic dysfunction, which means that the patient may, if you could please mute yourself if you are not speaking, thank you so much. The pupils may be fixed and dilated, and this actually is a reversible problem. So this will go away with time. I would not assume that patients are brain dead or have brain death if they have fixed and dilated pupils. Another aspect of the disability survey is that patients may experience something called chironoparalysis. And this means that nerves and muscles become stunned due to autonomic dysfunction and vasospasm. And this leads to weakness, altered sensation, pallor, so a pale extremity, and they may also have lack of pulses. This is also a temporary phenomenon. The lower extremities are more likely to develop chironoparalysis than the upper extremities. And the key thing here is to re-examine the patient frequently and assess their pulses, see how pale the limb is, whether it is cold, whether they can move it or feel. And this should ideally reverse itself. And if it does not, then you should suspect another traumatic injury. In terms of exposure, as with all trauma patients, we need to address hypothermia. And in patients who have had a cardiac arrest from a lightning or electrical injury, normothermia or normal temperature range is recommended. We no longer recommend therapeutic hypothermia. For secondary survey, make sure to look for signs of compartment syndrome or rhabdomyolysis, since patients with electrical injuries are at high risk for this. I've included an image of a striker needle, which is one way of checking compartment pressures. So be suspicious for compartment syndrome if patients have pain out of proportion to your exam. Another unique aspect of the secondary survey in lightning and electrical patients is something called an arc burn or a kissing burn. So this patient likely had his arm flexed at the elbow, and the lightning or electricity jumped from his forearm up to his upper arm. So you may see these types of burns. Another unique type of burn in lightning or electrical victims, typically lightning, is referred to as the Lichtenberg figure, which has a very unique burning appearance. And this occurs because the lightning jumps from areas of least resistance. So if there's rain or sweat on the skin, the lightning will travel along that path. And this is another thing that looks scary, but is temporary and will reverse. Posterior shoulder dislocation is an injury to be aware of and can be caused by severe muscle spasms that accompany lightning and electrical injuries. And patients will have what's called the light bulb sign, or this rounded appearance of the proximal humerus on X-ray. So be highly suspicious for this. Also remember that lightning and electricity can actually cause a blast wave and therefore lead to blast injuries. The primary blast injuries are caused by the initial blast wave itself. So things like tympanic membrane rupture leading to loss of hearing, or pulmonary contusions due to bruising of the lungs. Secondary blast wave injuries are caused by flying objects or shrapnel, which can cause blunt or penetrating trauma to the patient. Tertiary blast wave injuries occur when a patient is thrown into another object, something like a wall, and this can lead to blunt or penetrating injury. And finally, quaternary injuries occur because of exposure to fire, radiation, or other environmental contamination caused by the blast. So let's do some take homes for lightning and electrical injury. Remember to use reverse triage, meaning that patients who are not breathing and do not have a pulse should actually be managed first, because this is a temporary phenomenon related to respiratory arrest. Dysrhythmias are common. Autonomic dysfunction can occur, like coronoparalysis and fixed dilated pupils. Burns can be deeper than anticipated, and blast trauma is also a possibility. And final take-home points for all types of burn injuries. Go through your ABCDEs. Always default to this when you're not sure what to do. Beware of inhalation burns and exposures to chemicals like carbon monoxide and cyanide. Fluid resuscitate your burn patients who have greater than 20% body surface area burned, and be suspicious for deeper injury in lightning and electrical burn victims. You should irrigate all chemical injuries until you have a neutral pH. Electrical burns, like I said, go deeper than expected, and use reverse triage for lightning. These are my references, and I'm going to turn it over to Dr. Alenyo at this point to provide some local context.
Thank you, Dr. Jessica. So now, after the physician handling this patient at the emergency unit, that's when the surgeon has to come in and do the plastic surgery. At this moment, allow me give the opportunity to Dr. Alenyo to tell us more about burns, how they manage burns.
Thank you very much, our moderator. And surely I want to thank Dr. Jessica, because all she tried to present is covered almost over a year in fellowship of doing burns. So thank you very much. To give you about the local picture, we have one burns unit in this country, and it's supposed to cover 47 million people. And I know that there are several satellite centers that are treating burns. So I appreciate this organization to allow us share knowledge with many of our colleagues that are distributed all over the country. So this is an amazing opportunity. In our country, we don't have the emergency physician dealing with the first arrivals. So the Kiruddu team is composed of the burn surgeons, the nurses, the anesthesiologists, the nutritionists, the physiotherapists, So we work as a team to try and do all the work together. So that being said, burns, as mentioned by Afande, is that you need to prevent it. Once you get burned, the complications that are associated with it are quite massive. And in our setting, there are two groups that are so many. The children, which is 0 to 5 years, because of the cooking environment at home. If we can improve, and this is in the slums that are nearing the country, it's very rare on the countryside. So if we can improve the way we cook by having stable cooking places, or at least surrounding those cooking places, will save quite a number of children. Then the other group that is a lot is those having epileptic or fitting disorder. They are usually not put on treatment because people are in denial for these diseases. And they go on to have careers like burning charcoal, cooking chapati, because fire, as we know, triggers the epileptic fit. So they are exposed to fire and they take so long getting burned. So because we have only one burns unit, so we tend to receive many of the severely injured patients. And because I'm just going to go through in bits, because Dr. Jessica did all the amazing part of the physiology and care, is that for us to improve the morbidity or the mortality, let's say survival and the complications of burns, is to try and treat them first from the first time that we see them. So everything starts at the point they get injured. So these patients have to be cooled down by tap water. If you don't have tap water, even a soda which is in the house can be used. I know that's expensive, but most times we have been trying to apply urine, to apply things that pose a risk to these patients, because remember, burns is a disease that is entering through the skin, and skin is a major protector for infection. So the approach that people give are more risky to these patients than actually helping them. And then the other thing is the referral system is slow. Those that, like she mentioned, that there are some patients that need to go to the burns unit, and she clearly said them, if somebody has burns in the primary areas, like the child that was presented had burns in the hand, I am glad all went well with that patient. They were concerned about the digits, but clearly in the picture, it did well. So patients that have got primary areas, and primary areas are the face, because we have the eye, the nose in that area, the perineum where we have the vital organs, those patients must be sent to a specialist after resuscitation. And resuscitation has been said very, very well, because as I mentioned, that these patients lose skin, but sometimes it is just inhalation injury where they don't have the skin burned, but because I think, as Afande said, recently we have 2 girls die in a house because they were cooking with a sigiri. They had very poor ventilation, so they closed the doors and they went into sleep while something was cooking on the sigiri or the charcoal stove. But they were found dead in the morning, a 15-year-old and 17-year-old girls. So sometimes the little girl, I think, came to the hospital, but sometimes people don't get burnt, which we see the wound. They inhale those air which have got carbon monoxide, cyanide poisoning, so they reach with either hoarse voice or they are unconscious, and as they said, oxygen is life-saving in this case. So you just put on oxygen and monitor them. And the other thing that I wanted to say is that burns is not a local disease, it is systemic disease. It depends on how much you are burnt, but when you are burnt more than 10%, the whole of your body will respond. The central nervous system, the respiratory, the kidney, the heart. So most times when people see somebody is burnt and they are talking and they have reached the hospital, they think, oh, well, all is done, but it's not all done. So as it was presented, we need to approach the ABCD of these patients to check the primary survey and monitor them for secondary survey. So I think assessment has already been done. In our burns unit, we prefer to use the Lardner Browder chart, where already the drawing is there and you just have to mark it. It's more efficient and it's safer. You tend, if you use a rule of 9, you tend to overestimate the surface area, and that is where over-resuscitation takes place. But to speak bluntly, in our country, it is under resuscitation that takes place because we don't think about calculating this fluid. Once we connect a drip, is standing up, that's it. But for the burns, you have to sit looking at this drip that it is moving. And we are now modifying a chart that I think if somebody would help us distribute to the lower health units. We've been helped by Interplus from Holland that have given us a burns chart that has the drawing for marking the surface area, but it also has behind it what after adding, how you can calculate the fluids, how much you can give, depending on the weight and the surface area band. So everybody from that can see this patient, doesn't matter the level, not a doctor or even a nurse, anybody can use that chart and resuscitate a burns patient because they are always arriving with 1 bottle of fluid given. And of course, our burns unit has only about 45 capacity. So we rely so much in our other people trying to treat the mild burns. And if a burn is in the hand, please try to splint the hand in a functioning position, because most of the time they come with a superficial burn, like that baby we've seen presented. I think it is better to follow that baby and splint that hand, because in a film, it's partial thickness, it has not, because when a burn is very superficial, it heals within, by 21 days. Any burn that goes beyond 20 days has the tendency to contract. So that baby may surprise you in 3 months coming with a claw hand. So we need to follow those patients and make sure that they have a simple splint, will save us money and will save the child from having several surgeries to be done. I'm just trying to be brief because I think we've short our time as the clinicians. And what else? I think I also wanted to say something about the blisters. There's always a lot of talks in our setting about the blisters. The textbooks say if the blisters are less than 2 centimeters, they really don't bother, you can leave them. But sometimes the blisters are expanding and they get bigger and bigger. If it's in a joint, the person can't fold the joint, it's in the eyelid, they can't open their eye, or is obstructing the airway, or they can't eat. You can actually pierce and drain it. But the skin is good. If it's done in a sterile way, you don't have to clean the skin away. Just release the fluid and dress that wound and it will be fine. Because the next dressing, they will be dry and even fall off. And then something that I wanted to add on, maybe to emphasize, as Dr. Jessica said, was irrigation. If we are irrigating chemical acid, acid burns in our setting is targeting the eye. They always make sure they want the person blind. So when we are irrigating, we should not forget to irrigate the eye as much as we can. It might be the only thing that will make that person have vision. So we should not forget to irrigate the eye. And we don't have litmus in our homes. So we always advise people that when you cut off the acid clothes, put it in a polythene bag and send it along to the hospital. Probably government chemists will be able to determine what was the acid that was used. I think other things probably will come out as we answer questions.
Okay. Thank you very much, Dr. Alenyo. I love the way they have wrote out the management, how they manage, and they have put more emphasis on following the ABCD approach, and that goes to the pre-hospital and also the nurses after receiving your patients at the emergency unit.
And maybe what I forgot to say was about antibiotics. It's a controversy. The people from where Dr. Jessica come from probably don't use antibiotics, but for us, we have patients that mostly present late, and also the type of first aid materials used increases the risk for infection. So we tend to use antibiotics early, but otherwise, if a patient presented immediately from the burn, it is sterile, we should use topical antibiotics like silver sulfadiazine, which is very cheap and easily available. Sister, I think we'll mention about that. Yeah, and then hypothermia was mentioned. Thank you.
Thank you very much. So still they are emphasizing more about maintaining the ABCD approach, which will help you manage this patient. Usually in the field, the first responders and the nurses, we usually not mind about consider the inhalation burns. We focus on the wounds that we are just seeing. So we should also put in concern the inhalation burns. We consider the voice, as doctors talked about, the hoarse voice. Try to look out the signs. How is the airway? Is our patient breathing well? We try to assess the airway. Still, Doctor and Afande Walusimbi are still emphasizing more about prevention. Prevention is better than cure, because this is a serious case. For a burn, it will lead to more complications. So prevention, let us all try to prevent. She mentioned out the slum areas in Uganda, which is, I think, a clear case study in Uganda. Through the cooking environment, it has also increased. If we check the statistics, we see that most of the burns of babies under 10 years, they are from slum areas where the cooking environment is not good. Then also the first aid management of cooling with water, that would be the first management, which will help the patient, instead of using these other managements of using the vaginal fluids, cooking oil, putting sugar on the wound. So let us try to maintain the approach for the survival of our patient. Then this goes to the EMTs and also the nurses. She pointed out on calculation of fluids. This is very important. Remember, our patient has been exposed to burns, and these burns leading to leading to low level of fluids in this patient. So as we are giving fluids, we should focus on giving enough, not to overload or to give underdose of the fluid. So the calculation of fluids, it will be something very good. And she talked about the chart that is being designed, which will be helping whether a nurse or a physician to give fluids, which has been a good initiative. At this juncture moment, in our system, after a patient of burns being managed by a physician or a surgeon, a plastic surgeon is sent to ICU, and that's where a nurse has to take care of this patient. So let us hear from our nurse, the expert, on how they take care of our patient after the doctors being there. But thank you very much.
Thank you very much, the moderator. My name is Nacho, nurse at the burns unit, Kiruddu National Referral Hospital. I'm going to discuss the nursing management of a burns patient. And this management comprises of 3 phases. Usually we have the resuscitative phase or the emergent phase, and then we have the acute phase or active phase, and then lastly we have the rehabilitative phase. So during the resuscitative phase, usually we look at managing a patient as an emergency. At our facility, when a burns patient comes in, the patient comes directly to our unit because it is an emergency and we handle emergencies. So this resuscitative phase usually begins at the time of burn injury, and the focus is to address immediate and potential fatal problems caused by the burn injury. Usually managing a patient does not start directly from the hospital, but where the patient has gotten the injury. And this usually depends on the total burn surface area, the location of the burn, and then the depth of the injury. As the previous presenters have, pointed it out, we usually look at ABCD approach, whereby when you receive a patient, you have to look at the airway. Is this patient's airway patent? Is this patient able to breathe? Dr. Jessica talked about circumferential burns. Usually, when a patient has such an injury, his or her respiratory system is going to be compromised. So you need to take up the vitals, that is, you have to count the breath rates and then look at the chest expansion. Then we have to look at the circulation, look at the peripherals, and usually we have to take blood pressure for this patient. You know how this patient is circulating. Then we look at the disability. Majorly we look at the neurological disability. Usually patients who have been in house fire have can get exposed to neurological deficit, so you have to look at that also. Then look at the exposure, expose this patient, and then look at other injuries. For example, a patient might have been involved in an electric burn. Usually these patients follow from, maybe from a building, so you have to look at, do they have other injuries? For example, fractures. Then you have to remove extra clothes on this patient. If they have rings, you remove rings, and then keep the patient warm. Then also we have to monitor vital observations for this patient, that is blood pressure, pulse, the breath rate, and then AVPU, whereby you have to ascertain if the patient is alert. Are they able to respond when you talk to them? Are they in pain or they are unresponsive? Then we quickly establish an IV line. Usually you can use a cannula of a bigger gauge, because this is an emergency. We have to, to resuscitate a patient as quickly as possible, or you can use a central line. So any that is easily available. Then we quickly assess the burn surface area using the lungs and broader chart, just like Dr. Alenyo has told us, because this is what we have at our facility, and it is convenient because it covers all the anatomical parts of the body. Then we consider administering oxygen to patients who have respiratory distress. Then we have to replace fluids using the Parkland formula, as Dr. Jessica has discussed. Then our main goal of fluid replacement is to make sure that the patient at least has 30 or 50% mils per hour as an output. Then these fluids can be crystalloids, that is Ringer's lactate, or sodium chloride, but we prefer Ringer's lactate. Then we can also use colloids, that is whole blood, fresh frozen plasma, albumin or dextran. Then we have a formula, just like our previous presenter said. We usually use the Parkland formula, which is 4 mils times body weight times the total burn surface area. And usually we give these fluids, you divide the number that you've gotten into 2. Then you give the first in the 8 hours, the first half in the 8 hours, then the next in the remaining 16 hours. Why do we want to calculate this? Because usually we give patients a lot of fluids than what we need or less. So you need to have this in your mind, whether you're the referring nurse, you have to calculate these fluids. Then we usually have a problem of, some facilities referring a patient, just like doctor had said, when they've only given 500 mils of Ringer's lactate. Just imagine a patient has 85%, and you're referring a patient from maybe Hoima Regional Referral Hospital. By the time the patient gets to Kampala, we would have already AKI. So then another thing, you have to pass a catheter to monitor the input and output and record on a fluid balance chart. Then note the color of urine. Yes, because we want to know if our kidneys are fully functional, because one of the complications of burns is acute kidney injury, and the only way you're going to see that is the color of urine, and maybe after when you do some investigations. Then another point to put across in the emergency management, we look at temperature regulation. Usually our patients lose a lot of heat, which predisposes them to hypothermia. We usually get patients at our facility. I've witnessed this with patients who are brought in by police. They're usually not covered, not with anything. You get this patient and seriously, you don't know where to start from because all the veins have collapsed. And sometimes these patients are referred in at night. So when you're referring a patient to the hospital, at least make sure you cover the patient with anything that is available. Usually we use blankets or warmers to maintain this patient's body temperature. Then the other thing we look at is pain management. As nurses, as health personnel, we have to manage pain as quickly as possible in this case of burns, because these wounds are very, very, very painful. Just imagine you burn your finger. It is very discomforting, very painful. How about a patient who has 85% burned? So you need to work upon that. Then as you're managing this patient, you have to provide reassurance, tell them they're going to be fine. Then before you do dressing, you have to use analgesics. Then still in the resuscitative management, we look at wound care. Here, the goal is to keep the wound moist and free from infections. Before you carry out the dressing, you have to assess the burn size, look at the color, the odor, the exudate. As we saw in our case presentation, the patient had a past discharge. So as nurses, you have to look at that and note it and then notify the surgeon or the physician. Then you look at bleeding, the granulation tissue, status of the graft, that is if it was done, and report significant changes to the physician. Then also observe sterility, because our primary goal here is to minimize infections. So as nurses, we know how to do this very well. Then we look at dressing wounds using the non-adhesive materials. We use normal saline and sulfadiazine cream as an antibiotic. Usually, most health workers use cotton and put it directly on the wounds when they're referring these patients. This practice is very wrong. We usually use gauze and cotton, but there is a way we package it. Use gauze on top, then cover cotton inside. So when you're dressing these wounds or when you have to remove these dressings, it is not so painful. So we have to look at that also. Then we have the active phase. This phase lasts until the wounds have been fully covered. Wound care here is continued. Remember, we had wound care in the emergency phase. So here we are, trying to manage the patient after 3. What I forgot to tell you is that the golden hour of burns is usually from 0 to 72 hours. That is where we have to focus more on managing this patient as an emergency. Then dressing changes are usually done after 3 days. That is our practice as a facility. Unless if these dressings are soiled or wounds are septic, then we dress on alternate days. Then we have, as nurses, we have to assist, instruct, and support patient and family take part in dressing changes. This usually helps us to make the patient ambulate, to exercise around, and also to cope up with the situation. And when we are doing these dressings, we usually consult the anesthetic team. Just like Dr. Rose said, this is a collaborative management. We don't work alone, we work with the whole team. So while dressing these patients, we usually consult the anesthetic team to give anesthesia to these patients before we carry out wound dressing. Then we have to look at preventing infections, provide a clean and safe environment for the patient. Then as nurses, we administer prescribed antibiotics. Then also we have to look at prevention of stress ulcers. These ulcers usually come in as a result of reduced blood flow to the GI and the mucosal damage. So our doctors, our physicians, our surgeons prescribe drugs like the H2 blockers, and then we administer to these patients. Then also, we have to look at the nutritional part of it. These burn patients need a lot of, proteins, and we can't do this alone. We collaborate with the nutritionists because these nutritionists know better than us. So we call them to come in and intervene to discuss the kind of management, according to the burn surface area of the patient. Then, as nurses, you have to insert an NG tube if protein goals cannot be achieved with oral intake. So you have to look at the percentage. You weigh, is this patient able, to achieve, are we able to achieve our protein goal using oral feeds or not? And with the input of the nutritionist, they will advise us accordingly. So when we insert an NG tube, we have to feed our patient every after 2 hours. And then as nurses, you have to health educate the patient and then the attendants. And also the most important thing here is to obtain consent from a patient. Don't just get a tube inserted. You have to explain to a patient, why do you need to insert an NG tube? Because there are so many scenarios where a patient will tell you, I don't need that tube. And they also have myths about those tubes. They will be like, when a patient has that tube, they are going to die. So as a nurse, you need to explain more and then obtain consent. Then we encourage the patient to take plenty of oral fluids. Then we encourage the family to bring nutritious and patient's favorite food, because we understand that during the course of treatment, these patients might lose appetite. So we need to, to feed them with what they want to eat. Then we encourage them to eat fruits for vitamins. Then as nurses, you have to weigh the patient daily and chart the results, because we want to know, is the patient improving or they're just deteriorating. Then still in the active phase, as we say, this is a collaborative kind of management. We don't work alone. In cases where we have, for example, in chemical burns, where the patient's eyes, are involved, we have to consult a pathologist to come and review the patient and then tell us how the patient. Then also we have psychiatrists on the team, because usually some of the predisposing factors to these burns, like doctor said, is epilepsy. And most of our people are not on drugs, and actually they deny. They will tell you, yeah, I don't have epilepsy. So we need psychiatrists to come in and, review these patients. Also, we've had so many cases of depression in chemical burns. Just imagine your whole face is burnt, the whole body is disfigured. A patient will go into depression. So you need a psychiatrist to come in and review the patient and then act accordingly. Then we also have the ENT on board, because sometimes when we have issues of laryngeal edema, we consult them and come and review the patient. If the patient needs intubation, then they work on that. Then also we have physiotherapists on the team. Usually they come in and advise us, help these patients to exercise, and this will help them prevent contractures. So lastly, this is our third phase of management, what we call rehabilitative phase or reconstructive phase. And our primary goal is to maintain or achieve normal range of motion. But how are we going to achieve this? We have to minimize pain as possible, because there is no way you're going to make a patient exercise. Like we saw in our case presentation, the baby's hand. Yes, that hand might have it, but just like doctor said, it can be, the baby can be at risk of, getting contractures. So you need to manage pain as well as, achieving the normal range of motion. Then here we'll also look at continued wound healing, prevention of scars and contractures. That will be achieved if, we involve the physiotherapists, if you have them in your facility. Then we look at cosmetic reconstruction. Usually with deep burns, we do reconstructive surgery And this is where we see grafts being done by our specialist, Dr. Alenyo. Yes, so it is also a rehabilitative kind of management. Then we look at the psychosocial counseling. These patients overstay in the hospital, especially if they're severely burnt. You need to talk to these patients, reassure them, tell them everything will be okay. Then we have physical and occupational rehabilitation. Many of these people get burnt and they spend a lot of time in the hospital, they are not working. So we involve the occupational team to come and engage these patients. They know how they do their things better. Then lastly, we have patient and family education. We have to educate the patient on how to cope up, and then the family too, because this is not something easy. For us who are in the burns unit, we have so many experiences. Usually people tell us that maybe for you people, you have, but it is called Mutima Gwakalwa in Uganda, but it is really, really hard. Just imagine you get burnt and 3 months, 2 months down the road, you're in a hospital. So it is not an easy experience. As nurses, we need to talk to these people. I would look at the complication of burns. I wanted us to look at this because these things are very serious, and as nurses, sometimes it is us who spend most of the time with these patients. So as a nurse, you need to be critical in managing a burns patient to prevent these complications, because if you don't, we shall lose the patient. So usually immediate complications, we have airway obstruction, we have anemia, we have a compartment syndrome, acute kidney injury, and death if you don't resuscitate this patient. Like I said, the golden hour is 0 to 72 hours. Whoever comes, a patient comes to you, you have to do the needful to prevent all these complications. Then later complications, we have sepsis, scar formation, disfigurement, especially with chemical burns, contractures, and then lastly, we shall have a Majorin's ulcer. Thank you very much for listening.
Okay, thank you, Madam Nuluh, for your presentation. And that's how a patient of burns would be managed. We have seen, starting from the pre-hospital of the person being burnt, the fire brigade approaching, doing its work plus the pre-hospital. Then the patient is taken to the emergency unit where the physicians and emergency physicians and doctors will handle the patient plus the plastic surgeons. Then later, the patient is taken to the ICU where the nurses will have to take care of. Still, they are putting more emphasis. Madam Nuluh was, as she was presenting, she put more emphasis on these burns. The golden hour, the first 72 hours are very critical. That's when you have to intervene with the burns and you manage them. And unless you go beyond, then that person we might lose that person. So burns, it is a serious case that we shouldn't just play around with. It is something that we have to present as quick as possible or intervene. Then we see that here comes in nutritionists. Since this person has lost some of his skin, we see the nurses, they work in hand with the nutritionists, and here they guide them on which proteins would be better for this patient to recover as quick as possible. She also talked about introducing an energy tube, and you have to feed this patient. Remember, as doctor was presenting, she also pointed out on this patient who might be having inhalation burns, might affect the airway, and this is where someone, while being fed orally, the food passes. So it is better to introduce an energy tube and you start feeding for that patient, specifically 2 hours. That here we are preventing the hypoglycemic, we are preventing our patient from getting more complications. And also pointed out on explaining the procedure. So fellow nurses and critical care providers, as you're working on a patient, before you do a procedure, kindly try to explain that procedure to that patient, because to him, he might not be aware of what are you trying to do when it is saving his life. Thank you very much, Nuluh. As we are, according to our program, we are going to the question and answer. Is Dr. Anita Alenyo Gaviano. Yeah, I hope we can have a demonstration, at least look at the dressing techniques, great presentations, and important topic. Thank you very much for appreciating. I want to thank everyone who is following us on the chats and also who have tried to send in their questions in the Q&A sector. Okay.
Could I ask a few questions?
Yes.
Sure.
Yeah.
So I want to thank the panelists for their wonderful presentations. They've been very helpful. I've seen a few questions that maybe we can address the experts.
Mhm.
So one would be for Dr. Alenyo, which is there's a lot of chatter about what kind of dressings you use.
Yeah.
So there's honey, there's tilapia skin, there's vaginal secretions, there's burn shields. So maybe you could try to address what you think makes sense
Yes.
in our local context.
Yes, thank you very much for that question. Dressing is either open or closed dressing. Now, in the open dressing, you just clean the burn wound and leave it open. Actually, it says in our weather, it's even best the wounds that are left open heal faster. But we have a challenge with that in that you need to change the beddings very frequently, maybe every 2 hours, well ironed, to isolate that wound. So it's a bit expensive for us in that way. So we opt for, because it's an open ward with so many congested patients, so we opt for closed dressing. In other words, we cover it. Now in closed dressing, true, there are many dressings that have been talked about. Honey is very good, bactericidal, but you have to get the right honey. There are lots of controversies as to which honey is the best. It's a little expensive, but we've also used the honey in our units. We've used the ghee, and we still get good results with ghee. It's nutritious to the patient, and it's also, because the best thing a dressing must make the wound moist. It's wounds that are kept moist heal faster. So anything unprotected from infection with a good general condition. So in our setup, we're using silver sulfadiazine cream, which is very cheap, easily available, and has got very, very low toxicity. So we use that for our dressing. In wounds that are easily bleeding, we will use Vaseline gauze because every time you pull it, you'll traumatize the patient, will bleed, so you can use. But a wound that is exudating within 72 hours, it's not helpful to use Vaseline gauze. So you use something that will absorb this liquid. And we change dressing as soon as you see a stain on your dressing. It's not about days and hours. As long as you see a stain on your dressing, it means your wound is communicating with the outside environment. Whether it's the same day that you had changed, you actually have to change it. So I don't know if I've answered the question, but all those dressings work, but you use what is available in your center and what is easily affordable.
Right. So thank you, Dr. Alenyo. And then I had a question for Dr. Jessica about fluid resuscitation. You mentioned the 2 formulas and using crystalloid. Is there a crystalloid of preference that you think we should be using in terms of normal saline or lactated ringers? And then there was an interesting question about what if so many of the burns we'll see here in Uganda will be 6 hours, 8 hours after the burn. How do you compensate for the fact that these individuals are presenting in a delayed fashion in terms of your formulas?
Both great questions. I would avoid using normal saline and preferentially use lactated ringers if you have that available, because it's more physiologic and you're going to be using a large volume of fluid. But that being said, if you don't have lactated ringers, then you should use normal saline. And if you don't have any crystalloids, then using colloids would be fine, as we've mentioned before. And then in terms of your burn formulas, I would still use something like the Parkland or the Brook formula, even if someone comes in a delayed fashion, but just guide your fluid resuscitation based on urine output. Someone may actually have an increased fluid need if they present in a delayed fashion because now they've had more time for insensible losses of fluid. So again, urine output is going to be your guide.
Thank you.
Okay. Any other comments?
Yeah, no, that's
Very good. Okay, we are having some questions here in the.
Somebody, I just saw
Okay.
it there, as you look for it, somebody is asking us to elaborate on pain management. The best pain management is patient-controlled analgesia, but, because you can't tell how much somebody is feeling pain. So, but practically, sometimes we don't do that, but we still use a rough scale from a finger of 1 to 10 for the patient to score their pain, and, and we use pain management very freely. There's no addiction because these patients are really, like Sister said, if you just pressed your finger on fire, the way you jump, so you can imagine if you have the whole arm with superficial burn, it's paining and burning. So we use it freely, pain management.
There's a question here, if transfusion is to be considered, what level of HB should be considered?
Blood transfusion is not being used as a resuscitating fluid, but sometimes the patients will present for, if a patient presents anemic, you have to look for the cause. Either they are bleeding somewhere, they try to jump out of a window and they've ruptured their spleen, because usually just getting burned and presenting that they shouldn't cause anemia. But yes, if a patient is anemic, has 7 is being used as the cutoff in many literature, because when you try to give them IV fluids, you'll dilute them more, so you'll tend to give blood if they have a hemoglobin of 7.
Okay, thank you. Then the next question, if the burn surface is covered with blisters, is it professional to break the blister and apply silver sulfur zinc cream? Yes, Dr. Jessica?
I would probably avoid popping the blisters if possible, just because there's a higher risk for infection. If they pop on their own, then that's fine to apply the sulfur sulfadiazine. I'll turn to Dr. Alenyo to see if she has another answer to that. Obviously, I'm in a slightly different context.
I think I agree with you. The skin that is on top of that blister is protecting. The blister skin is protecting the body from infection. You remember the skin is our mechanical barrier to infection. So that blister skin is safe. You don't need to break it. I mentioned when I was saying that you will only break blisters if they are sitting on the eyelid and they are so big and the person can't open their eyes. But if they're in the body, just dress them. Even dressing, some centers prefer dry dressing, and some centers prefer wet dressing. We do wet dressing. We just put the silveric cream and dress them.
Okay. I have one other question. There's someone in the chat who says that they've had severe burns.
Yeah.
And they understand that there's a lot of kind of psychological stress associated with that. And they're wondering, are there Ugandan organizations that support individuals who've had severe burns in their recovery? And maybe you'll see that in the burn unit, maybe you'll see that from a public safety perspective.
Yeah, that's a very, very important part of burns care. If you read, there's a lady that got burnt in World War II. In 40 years, she was still having surgery to try and improve. So burns is very traumatizing. We used to have in our unit a psychologist that would go through with these patients. For some reasons, she's no longer available. But we had Acid Survivor Foundation there, that was trying to help those that had acid burns. And there's another association that I can get their contact and pass it on. They are also trying to help people recover from the burns. Yeah, it's very traumatizing.
Okay, if
Maybe.
okay.
Maybe there are situations like for me, what happened to me actually. There are times where you reach and you don't want to interact with people. Because like me, I got this problem when I'm on duty. I was trying to save some people and then I got a problem. But so many people, they talk against it and say, maybe we are stealing, maybe we are doing that, maybe they. So sometimes the community itself where you are tend to create that to you and you end up isolating yourself because you don't want to answer such questions. And if you don't get some doctors who can help you, you will end up maybe totally traumatized and then you feel like, and what I was advised, change the location and go to the environment which is new, at least. And then I went up to my village there are very few people who could come and ask me so many questions. But this one also come to see you after. They will begin interrogating you, asking you different questions, and you end up, and sometimes, like now, for me, sometimes I say, these things, are they growing? Am I going back to? So sometimes you feel maybe, will I go back the same? No, I don't want that. You get questions and you answer yourself, you end up keeping quiet, and then it happens in the society. So if you are not so brave enough to go out to the community and begin say, I'm going to help in A, B, C, D, it becomes very difficult. Like me, I decided to go out, roll out, and then you talk about I became a teaching aid actually to people who have not got the same. My fellow workmates. I also told them no. Not having this, when you get such people, try to treat them like this and this. And there are so many friends of mine who got banned. But because of I've been talking to them and I have contact people who can help us, they're okay now. Yes.
I see that Dr. Mary Ellen Lyon has her hands up. I don't know if you want to make a comment on that, on the past couple answers?
I'd like to, if I could, can you hear me?
Yes.
Okay, sorry, I just have a slightly unstable network. I'm the doctor that mentioned that I myself have extensive third-degree burn scars over my body from my nightgown catching fire when I was a child. And I've just been struck especially since being here in Uganda, by the degree of community that many WhatsApp groups are able to achieve. I mean, when I was working on the Ebola response effort last fall, there were some of us that, I don't know, I really felt like I was a member of a community in a couple of the, those groups that we were on, just kind of daily way to touch base with people going through a horrible experience together. And so I just wonder, even if a WhatsApp group of burn survivors might not be accessible to, of course, not everyone, but to many people across the country. It'd have to be, I think, based obviously somewhere here, like based maybe out of a major burn unit, but even something as relatively simple as a WhatsApp group could be an enormous resource for someone alone, a sole burn survivor, perhaps in a village somewhere, or even just in an apartment in Kampala, that's feeling very isolated, because there's really, you either have disfiguring scars or you don't in our society. And I think it's one of those things that you need to share the experience to really understand the experience. And I wonder if that might be an idea. Anyway.
Okay, thank you very much. We shall receive one question from the people who are online. If you have a question, you can just raise up your hand, and then we choose and you unmute. Okay, Isaac Mubezi.
Yes, thank you very much. I'm a surgeon upcountry in Uganda, and thank you for the great presentation. This is very good. Mine is straight to Afande Walusimbi. Are there some trainings that are done to, with the police in regards to first aid care to burn patients? Because some of our frustrations at this district hospital is that the patients are brought, but I mean, they are brought on the pickup truck, which is okay, but they're just thrown there. Is there something that is done that we can hope to offer point of care as first aid? Thank you.
Thank you very much. In these cases, they have tried to get some ambulances that can improve the way we handle patients, but it is not yet rolled out in every district, in every unit. Where we have got a big challenge that whenever there is a problem, in most cases, very difficult to access the ambulance. In most cases, they use the available means, and that's why they don't follow all the precautions and how to handle such a patient. But what they put first, they just say, let us rush this person to the hospital. And in other country, it is not yet, most of these are not facilitated, if I may say so. Because in most cases, you have these 9-9s, and you find the ambulance has gone very far, it's operating in a bigger area or jurisdiction. And what is there is what they use. So, but according to the medical team we have at maybe in Uganda Police Force, they are trying to secure some ambulances and put them in different regions that can assist. But in most cases, we find that there are different incidences and you have only one ambulance or two. And what is available is those vehicles which are used for patrolling. So it is not yet that it's handled in a very perfect way, but it is in the plan that they are, at least they are adding more so that they can be helping people in different ways. Yes.
Yeah, just to supplement on that, as we all appreciate that EMS is still a baby in Uganda, the government and the Ministry of Health under the Department of EMS, they are trying to procure some ambulances where they are trying to put EMTs, and every time there's maybe a fire outbreak, as fire brigade is activated, even some ambulances from Red Cross, KCCA, Ministry of Health are also activated to respond. And this, with time, it will be it will bring in some effective response. Yeah, but then we appreciate where we are. Yeah, as our post-test is running, we can receive one question. One question from the people who are following online, as we also work on our post-test. Yes, Rachel Mugera.
Thank you very much, especially our presenters. My question is, do amino acids have any role in burn management? Since someone is losing a lot of proteins, thank you very much.
Sorry?
Amino acid proteins, IV intravenous feeding.
Okay.
Thank you very much, Jessica. In burns, we try as much as possible to re-establish enteric feeding. It has advantages to the patient because we want the gut to be active to avoid translocation of bacteria, developing paralytic ileas. So we try as much as possible. And patients that have been on intravenous feeding quite have been documented to have poor prognosis. But once in a while, we've used the intravenous feeding, yes. So, but not on a large scale.
Okay, thank you very much. As we come to the closure of our session, we appreciate everyone who has secured some of her time and his time to attend the session and get more skills in the medical field. Every day is an opportunity to learn. And I know that we have got some skills from the experience that has been shared from the experts, how they have been handling these cases. I appreciate and I know that we have gotten some skills that in case we get such cases, it will be very easy for us to apply the knowledge that we have got from here. We thank CIT Global, Ministry of Health, under the Department of EMS, and all the stakeholders. Thank you very much, and appreciation to our panelists, the experts, for willing to come and share with us. Thank you very much.
Thank you, everyone. I shared the poll questions and answers in the chat if you want to review those on your own time.
Thank you, Dr. Jessica, and thank you everyone for attending. We are running the polls for the last time. We also have polls that evaluate the session, how the session was. These are general questions, so you could click on the answer of your choice, maybe say something was not clear. So it can help us improve on how we can run these sessions. But we appreciate your attendance. Like Dr. Gaba mentioned at the start of the session, he said that we are ending this phase of training and it is ending after the next session, which is coming in 2 weeks. We shall be handling blast injuries. So we encourage you to attend, those that are interested in getting certificates, but also for your own patient care and knowledge. You attend, and then we shall be moving on to the next phase. For the people who are attending in groups, who sit together and share a device, we've seen Team Yumbe sharing a device. We appreciate you for using the limited resources so that everyone benefits from such sessions. So the polls are running. Those that have not yet responded to the polls, please respond. We are going to share the materials and the recording to this session via our YouTube channel, and the presentation will be loaded to the website. The link to the website is shared regularly, but also we can share it on WhatsApp and also in our follow-up emails. Before we head to the screenshots, we would love to call on the experts to give us their closing remarks. We shall begin with our case presenter, Eliab. You give us your closing remarks from this session. We appreciate your time to present our case in the EMS report today.
Yeah, thank you very much, team, the moderator, our team experts. What I would wish to say is that I encourage everyone always participate in these sessions because they help us to learn much, especially during the management of our patients in our respective facilities. Do hesitate to attend these sessions. Some it's not because of their own making, others are always busy, but I would like to encourage that everyone should always attend so that they can gain knowledge and experience. Because when we share experience with our experts, the likes of Dr. Alenyo, Dr. Jessica from US, we get more knowledge and shared experiences on how to manage our cases. I thank you for attending. Back to you, moderator.
Thank you, Eliab, for taking the time to make the case. Maybe let's go on to Dr. Jessica to give us your closing remarks.
Thank you, everyone. If you want to access the questions and answers that were in the poll today, I did post a link in the chat. I also posted a link to the PowerPoint presentation. You can feel free to review those on your own time. It was wonderful to be here, and I really appreciate your attendance, and thank you for your commitment to education.
Thank you, Dr. Jessica. Let us go to Afande Walusimbi to give us his closing remarks.
Thank you, everyone. I'm honored to be here. Maybe what I may say, there are things which really our people need to know. Maybe when you roll out, you need to sensitize them much. And then maybe I can leave the contact so that if there is a group to be sensitized, we're always available to avert some of the problems. And you can call us on 0800 121222. That is 0800 121 222. That number it goes to fire headquarters. When there is emergency, you always call us. Or maybe if you want to call one-on-one, like maybe you call me as an individual to come and train, sensitize actually. Normally I'm available on 0758 962048. It's also on WhatsApp. Any question when it comes to fire safety and burns prevention. But all in all, I encourage everybody, where possible, install the smoke detectors, the alarm system, change, you must be having at least 2 exits. Or also window samples, you can cut some burglar proof and turn it to be an exit. And also, where possible, even these workplaces design what we call the assembly points. There are so many things we need to do, but all in all, safety first. When you consider safety first, our people will always be safe. Thank you.
Thank you, Afande Walusimbi. I can't repeat your words, but we've all captured what he has communicated, and his numbers are posted on the chat. I will go on to Sister Nuluh.
Thank you very much for this wonderful opportunity. I would recommend Ministry of Health to at least come up with strategies of, sensitizing the community on how to prevent burns, because it is really a big problem in our country. If you're not on the burns unit, you will not appreciate this. But for us who are always there on a daily, we know how big the problem is. So I would recommend Ministry of Health to at least sensitize the community about all this. Thank you very much again for this wonderful opportunity.
Thank you so much, Sister Nuluh. We have captured your submission, and we are going to forward it directly to the Commissioner, who can discuss it with the rest of the ministry. Dr. Harry?
Yes, so thank you all for joining us today. It was really an honor to be here with the esteemed panelists. We heard a lot about the importance of prevention. We heard about the key importance of that airway in any inhalation burns and early intubation. We heard about the necessity to aggressive fluid rehydration, resuscitation guided by urine output, and then the importance of what they do in the burn unit, both in terms of the management of the wounds themselves, but also the nutrition and the rehabilitation. So this was very helpful. And again, I was honored to be a part of this.
Thank you, Dr. Harry. We'll go to Dr. Alenyo.
Oh, thank you very much. I feel so excited that burns is being considered as an important entity, because it used to be the burns patients were thrown at the corner of the ward when we were young doctors, and now I really appreciate this meeting, because there are many lives that we can save by knowing that we can prevent and knowing that early treatment is important. And like Sister said, that we also hope simply hotlines can help our colleagues in the countryside to call in before they refer, or sometimes they try to treat and they don't have much information. But if we have a hotline, they could have information that will help them resuscitate better. And by the time they refer, the patient is in a stable state. So I appreciate, and I'm so excited to see over 400 people listen to us talk about burns. Thank you very much, everybody.
Thank you, Dr. Alenyo. We appreciate you sparing time to attend the session and also give knowledge to the people about bands. Our moderator, lastly.
Thank you, everyone who has been following us online. We appreciate SID Global, Minister of Health, EMS Department under the Minister of Health for always coming together to facilitate this. Maybe my kind request would be on how Minister of Health, specifically EMS, the pre-hospital section and fire brigade on how they could work together to see more lives are being saved. Thank you very much.
Thank you so much. Moderator, we appreciate everyone for attending and we would love to see you in the coming session, which is going to happen in 2 weeks. Thank you all. Have a great weekend. Those that are able to turn on your cameras, you can turn on your cameras and we take screenshots. I can see Simon with Team Yumbe. We appreciate your presence and attendance as a team. And anyone with a final comment, we love appreciating internationals. Any internationals on the call apart from Dr. Jessica? Do you have any internationals? You can unmute and tell us where you are attending from.
Hello. Hello, everyone. I'm Daniel from Saudi Arabia. I'm an anesthetist, and I'm happy to be here. Thank you.
Thank you for attending, Daniel. Any other international?
I had 3 participants
I'm also Belinda from Ghana.
Thank you for attending from Ghana.
Hello.
Hello.
Good afternoon. This is Nur Aziza from Nigeria. I'm happy to be here.
Thank you for
good afternoon. This is Benjamin Kana from Ghana. Thank you for the presentation.
Ghana, thank you for attending always.
Rosaria from Angola.
Oh, Rosaria from Angola. Pleasure to see you on the call.
Thank you.
Samuel from Somalia.
Somalia, thank you for representing.
Samuel from Somalia.
Hello, everyone.
Hello. Okay, thank you all. We can see Esther. I don't know if you're international, but all internationals, we appreciate your time. We'd love to wish you a great weekend. See you in 2 weeks. If you have any questions or queries, you can send your concerns via the emails that texted you to tell you about the session, but also you can go to info@emsecho.ug. You can send any question or any concerns to that email addresses. Thank you so much. See you in 2 weeks.